All right, good afternoon, everyone. My name is Deanna Fenton, Program Manager here at the Alliance, and it's my pleasure to welcome you all to today's exciting innovation webinar on the breakthrough concept of organ cross-circulation and its potential to support organ recovery and regeneration. Before we begin, I'd like to take this opportunity to extend a sincere thanks to our webinar sponsor for today, CC Change Surgical. CC Change Surgical develops, manufactures, and markets Surgery Slush programmable auto freezers and protective containers. Surgery Slush delivers control of slush supply, automates optimal slush quality, and significantly increases efficiency during the procurement and transplant procedures. For more information, please visit ccsurgical.com. Now, for anyone joining us for the very first time today, please note that your audio lines have been muted and will remain muted for the duration of the presentation. Bearing that in mind, if you have any questions for our presenters, we'd like to ask that you submit them using the Q&A box located at the bottom of your Zoom window. Once the presentation has concluded, we'll go ahead and transition to our Q&A discussion where our presenters will address as many of your questions as time allows. Now, should you be joining us as a group, we'd like to ask that you take this opportunity to complete the following poll and indicate approximately how many people have joined your group. Your responses will ultimately help us and our presenters gauge a level of engagement and participation in today's program. Now, for anyone interested in attending any of our remaining programs of the year, please note that registration is currently open for our next donation-focused webinar, which will highlight the importance of C-suite connectivity to improve hospital and OPO collaboration. Be sure to join us for that next week on November 2nd at 2 p.m. Eastern. Likewise, registration is open for our special edition webinar that will address a very critical topic impacting our community right now. During this webinar, we will discuss the ongoing challenges of hiring and retaining staff and share insights and strategies on how to overcome those challenges. You won't want to miss that discussion, so please be sure to join us on November 4th at 2 p.m. Eastern. Now, as always, to stay up to date on any of our upcoming programs and to register, please visit our website at organdonationalliance.org. Lastly, for those of you who are interested in continuing education credits, please note that we are offering 1 nursing contact hour and 1 sepsis credit will be awarded for your participation in today's webinar. Additionally, of course, there's a certificate of attendance that's available for anyone that's not seeking CEs. Anyone joining us today is eligible to claim any of these credits mentioned, but prior to receiving your certificate, you will be asked to complete a brief online evaluation, which will allow you a great opportunity to provide us with your valuable feedback. If you happen to be listening in a group, please be sure to get the evaluation email from your group lead. As a friendly reminder, you'll have 30 calendar days to complete your evaluations and claim your credits. Now, with all that said, I'd like to go ahead and begin today's program by welcoming our moderator, Brandy Zofke, Director of Lung Bioengineering at Lung Bioengineering, Inc. Brandy, without further ado, I'll go ahead and turn it over to you to begin today's discussion.
Thanks, Deanna. It's my pleasure to introduce today's webinar on organ recovery and regeneration for transplantation. This webinar will really be introducing the breakthrough concept of cross-circulation and its potential to support organ recovery and regeneration in the future. I mean, with all of the advancements in organ transplantation, still only about 1 in 5 donor lungs are actually used in transplant. So in order to capitalize on being able to maximize the organs available, we're going to need to have some innovative technologies to be able to do that organ repair. And with the limitations in the technologies that currently exist, could there be a possibility of extending what supply currently is available? So it's my pleasure to introduce to you today Dr. Matt Bacchetta and Professor Gordana Vunjak-Novakovic. Dr. Bacchetta is a lung transplant surgeon and funded researcher at Vanderbilt, and his clinical work focuses primarily on end-stage lung and pulmonary vascular diseases. Has one of the world's largest experiences in the use of mechanical devices for patients with both acute and chronic respiratory illness. And today he'll be sharing with us some of his own research developing platforms for organ recovery, regeneration, and replacement. I'm also proud to introduce him as having served in Iraq and Afghanistan in the US Army. Gordana is a university professor at Columbia University, which is the highest academic rate at Columbia University, and the first ever engineer to receive this distinction. Her lab focuses on the engineering of functional human tissues for use in regenerative medicine and is well published and highly cited, which is probably the greatest understatement if you look into her history. And her lab alone has launched 4 biotech companies. She serves on numerous councils, and editorials, and scientific advisory boards, and we are so thankful to have the 2 of them here presenting on their collaborative research today. And with that, I will turn it over to Dr. Bacchetta's presentation. Enjoy.
I'd like to thank the sponsors for the opportunity to speak about cross-circulation, old concept, new paradigm for organ recovery. These are my disclosures. The need for increasing the number of usable donor lungs is apparent probably to anyone who's watching this right now. We have a waitlist mortality that continues to hover around 10 to 15% per year. And unfortunately, we only can recover about 20, maybe 25% of all available donors for lung transplantation. And so there are a huge number of donor lungs that unfortunately at the time of procurement are determined not to be usable. So the major question for us is, how do we expand the donor pool? And then we've taken several approaches to this. We've used sort of expanded criteria lungs. We use DCD donors. We've started to use ex vivo lung perfusion, EVLP. We're trying to bioengineer lungs. We're trying to develop artificial lungs, and xenotransplantation efforts continue as they have for a couple of decades. So where are we with the state of the art for ex vivo perfusion? Because and these efforts are really aimed at trying to recover that marginal quality organ, or an organ that we're not really quite sure of. There may be a couple of issues and we really want to assess them. And these are 2 of the major competitors out there. There are several different systems and approaches, but the idea is that you can take this marginal lung, you place it on the system, and then you have a limited time to intervene. You can pump these lungs for upwards of 6 hours. Some groups pump them longer. But what you're really looking at is there's an initial cold ischemic time. Then we do EVLP, and then there's a second cold ischemic time. And you can push this out for maybe 18 hours. There are groups that have published that total time has been up to 20 hours. The problem is that there's still a very limited time to intervene, and it's really not 18 hours. You have about 6 hours on pump. So this creates severe limitations for ex vivo organ perfusion. And the reason for that is because, in this case, we're trying to recover an injured donor lung. The problem with these isolated machine perfusion systems is that there is no kidney, there is no liver or pancreas. In other words, we're missing a normal physiologic milieu, and you need that type of homeostatic regulation to enable extended normothermic organ support. And that's really the only way these marginal organs or lungs that have severe reversible injuries can recover and regenerate. So we really struggled with how to extend the physiologic support that we needed to allow these organs to recover, truly regenerate from their injured state, a reversible injured state. And this is where you have the old concept, new paradigm. So reflecting on this brought me back to the time thinking of Walter Lillehei, who in the 50s used cross circulation to enable the surgical repair of congenital heart defects. And it was through this idea that I came up with, and with my colleagues, that we would use cross circulation to allow the recovery of these organs, because it would provide that full physiologic support. So this is what it looks like more on a human scale model. This is one of our earlier experiments in a swine model. And this led to a publication in Nature BME a few years ago, where we really focused on taking lungs that had a prolonged ischemic injury period and then placed them on the cross circulation. And what this did was this really enabled us to push the time out to about 60 hours. And we did a multi-scale assessment interventions on this. And what we found was that the lungs did remarkably well on this system. They recovered their function, their gas exchange normalized, their compliance normalized. In fact, their compliance continued to get better the longer they were on the system. And the other thing that was quite remarkable is that the weight, because these lungs can become quite edematous if they're left in cold ischemic state and fluid, actually their weight continued to decrease on the system. We had stability in a number of different measures that we used, whether it was systemic measures of D-dimer and fibrinogen levels, or whether it was also looking at levels of cytokine production. We also found that over time, actually at 36 hours, that the histology of the lung actually looked better and had returned to normal over time compared to the time zero. And the lungs remained functional as well. They continued over, even 36 hours to be vasoresponsive. They also were bronchoresponsive over time. And we were able to demonstrate that the type 2 cells were able to continue to process surfactant. And when we looked at a lung injury score, what we found was that the lung injury continued to improve. In fact, the lung was better at 24 hours than it was at certainly 0 hours and at 12 hours. And this speaks to the important point of the amount of time that is required for an injured organ to recover. It's not something that's going to recover in a short period of time. It's not going to recover in 3 hours. It's not going to cover, a severe injury is not going to recover in 6 hours. So when we looked at the cellular analysis for extended organ perfusion, we can see we maintained epithelial integrity, we maintained our vascular bed integrity, maintained our vasoresponsiveness, and we maintained our metabolic activity. This led to a paper in which we looked at regeneration of severely damaged lungs. These are lungs that we would never have taken for transplant, and we would never have considered them for EVLP because of a severe aspiration injury, which is one of the contraindications to EVLP. So in this model, we standardized this injury model to recapitulate what we would see clinically. And then we would ultimately place them on a cross-circulation system. We had multiple interventions, but while we were doing that, we were running lung diagnostics, as well as monitoring our therapeutic interventions and developing sort of a theranostic platform in which we can get this type of feedback and hopefully in real time to make adjustments to the repair and the regeneration of lungs. So here it is. This is a clinically relevant model. This is a very severe aspiration injury. You can see effacement of these here. And we would then procure these organs after this severe injury, which was done in vivo on the donor. They'd be explanted, we'd cannulate, run them on our. And as you can see, as we were doing interventions, whether it was airway lavage or surfactant delivery, stem cell delivery, you can see that the lavage actually cleared over 36 hours. You see very good uptake with the mesenchymal cells. So we go from this clinically relevant model, we take a look at our time zero imaging studies, whether it's a gross examination, X-ray, thermography, H&E, or endoscopy. And what we see at 36 hours or more is that this lung continues to improve. You'll see this on gross examination, from the X-ray, the thermography, and with the histology. This again is just showing a lung run out for 40 hours, and you can see that there's near normalization of the lung architecture, even in these severely injured lungs. The functional recovery was quite remarkable. The compliance continued to improve over time. The longer we were able to run the lungs, the better they got. And what's really important here, what I want to point out is at this 12-hour mark, it was really not until about 12 hours that we started to see a marked improvement in the gas exchange with oxygen. But we were able to maintain that and had normalization after 36 hours. This is just our histology, and what you'll see from a heat map is that, again, we have normalization. Importantly, you'll see the tight junctions are normalizing over time, and this continues again. Now, I don't want to sound like a broken record, but it gets better over time. So the support system is extraordinarily robust and stable, and that's exactly what we eventually took this into a successful transplantation in a pig. So the idea here was that we would then extend this into multi-day analysis, because obviously we realized that time is actually, as opposed to standard EVLP, time is actually something that we want to extend in cross circulation. So we developed a multi-day model, and this is where we would run these lungs for 4 days. And we were really focused on changing the metric, because when you're talking about EVLP, and it doesn't matter whether you're talking about lungs or liver or heart, we really speak about this metric in time, in hours and not days. And we wanted to change this. We wanted everybody to start thinking in terms of days and maybe potentially weeks. So this is a challenging model to do. You have to do swine training. You have to acclimate them to a new cage. So that usually takes a couple of weeks. Then you do a cannulation, and usually we just used a single site dual lumen, which was sufficient for blood supply and flow. Then once you recover the animal, you have to deliver the animal into a specialized crate. And that's what it looks like once the animal is awake and the system is running. Larger model. One thing that I want to point out and that we learned, and I'll go into the reason when highlighting static pressure matters here, is because, as you can see, the animal can stand, the animal can lie down to sleep, and that can result in a very large change in the height of the animal relative to the organ, upwards of, towards 60 centimeters. And static pressure matters when it comes to organ. I'll touch on that a little bit later. So what you'll see here is that over time we had stability in our cytokines. You can see on gross examination with the bronchoscope that remained normal. And the airways, despite being out for 4 days, remained bronchoresponsive to methacholine challenges. The metabolic activity of the lung was stable over time. And our lung function and compliance was stable over all 4 days. One thing that I will point out here is our lung weight went up a little bit. And that's where the static pressure came in. That was a lesson learned, because when the animal is standing, which it was doing quite frequently, and we were not adjusting the lung with it, there was a tremendous amount of static pressure within the lung, which then led to a little bit of edema, which would correct once the animal laid down. So we, in later designs, had to consider this. Support. And what I'll point out here is that on gross examination, you can see some areas where you start to get dependent edema. And it's just like with your patients. If they have ARDS, sometimes you're prone, or a patient that's just recovering from surgery. You don't want to leave them static in the bed because they can get pressure sores. The same thing can happen to organs. If you leave them static for days on end, that can happen. So we developed this tilt table to help with our runs in multi-days, because it would allow us to adjust that organ so that we could avoid pressure sores. So ultimately, this worked out really quite well. We had stability in our gas exchange, our compliance, the lung function, and the histology all remained normal. This led to our work in xenogeneic cross-circulation. And in this effort, what we did was we took acutely injured human lungs that were rejected, that did not meet transplant criteria. They were explanted, and we placed them on our cross-circulation platform with a swine. We used, I won't go into great detail about the immunosuppressive regimen, but it was fairly standard with the exception of the addition of cobra venom factor, which we use to shut down the complement system and helps prevent hyperacute rejection, which we verified in one of our runs where we did not use that as part of our immunosuppressive regimen. And what you can see here is obviously over a 24-hour period, the lungs continued to improve. We saw a marked improvement in the gas exchange over 24 hours. The compliance continued to improve. The peak inspiratory pressure decreased over time. Our CO2 exchange also improved over 24 hours. If you take a look at our lung injury score, it was markedly improved, going from where we are on this initial assessment of lung injury to where we were at 24 hours. This particular organ was really an incredibly important experiment for us. This was a lung that was placed on EVLP in the hopes that it might recruit. There was obviously a bad injury in this lower lobe. So it was rejected for transplant. The other lung actually did recruit well on EVLP, and it was used for a transplant, and that patient did quite well with that lung. But this is a lung that we would not transplant. But what you see over 24 hours is on our cross-circulation swine-based bioreactor model is that lung actually grossly started to return to normal. And the airways on histology continued to improve. And whether you're looking at the alveolar spaces or you're looking at the alveolar blood gas barrier, what you'll see is that over 24 hours there's continued improvement. And that includes the ability to handle surfactant metabolism. So we see that there may be a couple of different clinical applications where you could take an injured lung, send it to a patient where that patient would be on, that patient might be in the ICU, might be on ECMO, and you could potentially even do allogeneic cross-circulation support for these lungs because the patient has a functioning gut and liver and pancreas and so forth. Those lungs could regenerate, and then at the time, once they do and they meet criteria, you could then do the transplant. And instead of taking a patient, putting them through a very large operation with lungs that don't meet criteria and hoping that they will recover, you could wait until the lungs have recovered and then do the big operation. Alternatively, you could take these, bring them to a EVLP center. If they recover, they can go directly to transplant. If they don't recover, you can place them on a xenogeneic cross-circulation platform and then do the transplant. The research applications are manifold, and we're doing work in multiple organs. We've used this for liver and other organs. It's not, we know most of the work we've presented today, in fact, all the work we've presented today is on lung, but we have done this with other organs. But it also opens the opportunity to do the types of therapeutic and bioengineering interventions that you can't really do on EVLP because you don't have a stable platform for an extended period of time, certainly not for multiple days. So from our envisioned translational application obviously is that these injured human lungs that have severe injury, they do not meet transplant criteria, but it's considered a reversible injury, and they don't meet EVLP criteria, could potentially be placed on a xenogenetic platform. If they recover, they can go into a transplant recipient. You can also, as I said, you could take these injured lungs, you could put them on an EVLP, send them through a conventional isolated EVLP, fail, and then go through the human xeno platform. So in summary, there is a great disparity between organ need and donor organ availability. And this is really the driver. This is why the need for the innovation is really simply this disparity in what organs are needed and what are truly available. The current technology, the ex vivo systems, they do offer some support, but it's really a marginal impact on the donor shortage because of its physiologic limitations. For example, you can't put lungs that have aspiration injury on the system. The other thing that we can do is that it really does offer, because it's a functionalized lung graft, it allows us to really potentially do a lot of deep dive on the bioengineering of the epithelial airway. And that may offer potential treatment mechanisms for diseases like CF. The other last point that I really want to make here is that it provides a durable homeostatic environment for organ regeneration, even within our xenogenetic platform. And it's that extended recovery that's going to allow us to focus on rejected lungs, potentially make them better, and really provide the platform to conduct the long-term bioengineering and organ modification studies that we've. I want to thank, I have a lot of colleagues. This list is probably short of all the people that have worked with us over the years to do.
Thank you so much for your presentation, Dr. Bacchetta. And with that, Professor Vunjak-Novakovic, I will be turning it over to you. Thanks for joining us. Oh, Gordana, I think you're on mute.
Mute. Okay.
There we go.
Can you hear me?
Yes, ma'am.
Okay, that's good. So, we are giving this team presentation. So Matt gave really wonderful introduction into the clinical problem and the whole spectrum of options that the physicians today have available, and went over a lot of detail of what we have done. So I will try to reflect a little bit more on science/engineering component of our project. So it's interesting that we started this project the way we really like to do it, which is from understanding and managing a clinical need. You hear a lot today that people are talking about benchtop to bedside paradigm, which means you develop a product, you develop technology or methodologies, and then you go into the clinic and try to find application. What we have done here and what we really like to do is to reverse it and say that we start from the bedside, which means that you recognize a critical need for which you need very close interaction collaborations with clinicians. Then you go back to the lab to try to find the solution. And once you find it, then you are working back towards the clinic to turn this into the benefit for patients. So some 7-8 years ago, Matt Bacchetta and a couple of colleagues, transplant surgeons at Columbia, came over to lab with this problem that he already described, that there are not enough lungs to be transplanted to patients that come to the end-stage lung disease and really don't have any other therapeutic option. And he also explained something that I didn't know at that time, which is really shocking for me, that among the lungs that come from donors to the clinic, as many as 4 out of 5 are being rejected. So this is a real crisis. At that time, the field of bioengineering was attempting to bioengineer lung from scratch using either native or synthetic scaffolding materials and cells. And really all these efforts were failing literally hours after implantation of these grafts, because they were just not sufficiently developed, sufficiently functional. So you can make a piece of bone, you can make a piece of muscle, but you cannot make a piece of lung, not yet. The reason is that lung has more than 50 cell types. It's still being debated how many exactly. It has this, as you all know, incredibly complex architecture of the airway and distal lung and of the vasculature. And then between the two of them, we have some 145 meters square of gas exchange surface. Like for reference, tennis court is about 190. So this is this is like a marvel of engineering by nature. And so we came very quickly discussing together what to do to this idea that we should lower the ambition, and instead of attempting to engineer lungs, just to repair the lungs that are rejected, because they are not 100% dysfunctional. They do have a lot of functionality, just not enough to be useful for transplantation. So these discussions brought us to the development of these 3 methodologies that really merged into cross-circulation platform that Matt was describing, and I'll give you some additional detail. First of all, we understood that we need time to intervene on the lung, and that we need to extend the support that currently exists from hours to days. And this led us to connect the lung by vascular perfusion to the living host, and in addition to ventilate lung. And rationale to this is that the living host is really providing the homeostatic environment by processing all metabolic products from the lung, which is maintained ex vivo, and keeping it in a good shape. The other lesson learned was that in many cases, the lung is not uniformly damaged. Sometimes you have, for example, gastric aspiration, so there is like a pocket of tissue which is destroyed, and we developed technology that allows us first to visualize this area, and then second to approach it, so that we can remove the damaged cellular material and replace it with therapeutic cells, plus minus any other therapeutic agents. And the third piece of critically important information was that most of the damage is in the epithelium, and it is critical to maintain functionality of vasculature, to keep vascular supply at all times for obvious reasons. So we found a way to very gently remove damaged epithelial cells. We don't disturb the basement membrane. We obviously don't disturb the vasculature, which is on the other side. And then we replace this with therapeutic cells. So in these 2 immunostains, you see before and after image. Green stain are the epithelial cells, and you see that they're mostly gone during this process. And red are endothelial cells, which you see that they are largely preserved. So, So this is, there is a delay, I'm sorry. So this is how it looks. I mean, Matt already explained a lot of this. I just want to draw your attention to additional instrumentation that we brought to this OR. At the far left, you see thermal imaging that we are using to follow reperfusion of the blood, because if the tissue is warm, if it's at physiologic temperature, it means it's perfused with blood, and vice versa. And at the top right, you see the inside of the lung visualized by a very thin catheter that we were using to look inside the lung to see how the lung and the cells are doing. And then this under the drapes is our supporting animal, our host pig. But as Matt explained, there are scenarios where you may envision that the patient herself or himself may be supporting the lung that are about to receive by transplant. Just a few details of this technology that I mentioned to you. So just by through studies of fluid mechanics, we found a way how to, in a targeted way, very selectively, deliver very small plugs of fluid that can contain decellularization agents. It can contain therapeutic cells, or it can contain, say, a medicine, so you can deliver it into the targeted region in the lung. And this was the way how we started to treat the lung in a like a spatially defined manner. This was also, these procedures were assisted by many different modalities of imaging. One of them was the one I just showed you on the previous slide, which is looking inside the lung through a catheter that has an optical fiber, and then camera is outside. And we also have done a lot of transpleural imaging, because some of these materials can be labeled, and then you can really have some insight into what's happening. So what you see here, let me see to try to play this movie, is if you look at this, you see tracer particles that we introduced into the lung circulation, and you see them clearly moving through the lung. So this is something that was visualized in the lung from outside. And then what you see here is the before and after. So you see that the lung that was very compromised in the beginning is clearing very substantially over these 36 hours of intervention. And then through imaging, you can get all these beautiful pictures where you can trace the labeled cells and see where they are in the lung and what's happening with them. We went shortly after that one step further, which is to very selectively remove only epithelial cells, and also to selectively remove some specific types of the epithelial cells. And I want to emphasize by these images at the right-hand side that this methodology works also in the upper airway, in the conductive zone of the lung, as well as in the very distal airway, which is the respiratory zone of the lung. And my favorite image from these studies that were done with Valerio Dorello are these transmission electron microscopies, where you see that actually the finest ultrastructure of the lung at the basement membranes were really maintained during these treatments. So this was the first study where we started working with the porcine lungs. This lung was intentionally subjected to very serious hypoxia. This is mimicking some damage that normally happens during the transport of the lung. The lungs don't travel very well. And you see that the lung initially at the picture top left looks highly abnormal, with a lot of these pale areas that actually overlap with the dark regions in the thermal imaging, meaning that they are not perfused with blood. And then very clearly over time, so this is 0, 12, 24, and 36 hours, the lung is assuming more and more normal appearance. We then transitioned to much more clinically relevant gastric aspiration model, which is one of the key reasons for the rejection of lungs, because it's causing very, very serious injury to the lung that simply cannot recover on EVLP. So we asked ourselves if we would be able to really treat an injury that is above and beyond the capacity of current clinical methodologies. And just a small subset of data that you have already seen, but show them to make a point that actually these pressure volume loops are very markedly changing during the treatment. What you see here is a control loop, for those not very familiar with the lung, tells you that very small difference in pressure is causing significant transport of air in and out of lung. So if your lung is healthy, you breathe effortlessly. If your lung is very injured, which is this initial lobe, the red lobe at the bottom, then even if you increase several times the pressure difference, the transport of air is not much improved. And you see here recovery, the lung is moving towards this normal control. It doesn't duplicate the normal control, but it gets very, very close. And the same is the case with other functional parameters. What you see here is effectively the oxygen utilization. So it tells you how much oxygen that you breathe in gets into your blood. We start at subnormal range and we end up in normal range. And as with all our organs in our body, structure, function go hand in hand. So you see that actually during this process of recovery, initially very compromised tissue morphology with a ton of inflammatory cells is clearing and taking more normal appearance. Extension to 100 hours using this special cage with the animal that was moving and eating and playing over this 4 days, 5 days practically of operation. You see that there was ability to maintain and improve lung structure, to make the lung responsive to physiological stimuli. So there were a number of these challenges of testing the lung responsiveness that were used as a criteria of the effectiveness of the procedure. So the most exciting part is this more recent work. It was just published not even a year ago, where we translated technology to the human lung, to the xeno model, where human lung is supported by a porcine donor. So what was done here is we started from a total of 6 lungs. They were all declared research lungs because they were determined not useful for clinical use. So all these lungs were in a very bad shape. This is from the paper. You can see details there if you're interested. The lung number 5 was the one that Matt also highlighted, which was a real test of our technology, because this is the lung that came to us after some 30 hours of traveling between transplant centers, and there was no success in recovering it to any extent. So all these lungs really recovered very nicely. The functional properties improved and the structure of the lung also improved. So what you see here at the left is a sequence of 3 photos, just the gross appearance of the lung at the time when lung was received in a very poor shape. This is this here, and then 12 hours later looking better, and 24 hours looking much, much better. And the corresponding histologies that document these changes. So here, let me just show you a little bit more evidence, like from 3 different lungs. So you can see, like at the beginning and at the end. Just a second. Okay, now it will hopefully play. So just to see how the real structure of the lung and compliance of the lung. So there is this recruitment that you see very, very clearly, which is attained after 24 hours, starting from something at the beginning that you see at the left, and then they got with these lungs that are relatively recovered. Same here, I'm in lung 3, lung 4. So these are just 3 examples of the lungs that were recovered over only 24 hours on cross circulation. Very importantly, and this was documented for all lungs that were studied in this particular experiment, both the lung vasculature and the lung airway were maintained very nicely. So we could see cilia on the cells. We could see here what you see at the bottom right, the uptake of surfactant protein B in a video and also in still images. So this looks very, very promising. So the next step that we were very interested in was to document on this severely injured lungs that we can remove epithelium while not disturbing the surrounding cells in matrix. So after this was done, this capability allowed us to start introducing cells, therapeutic cells into the lung. We established methodologies just using mesenchymal stem cells that don't have too much effect on the lung. But once the protocols were established, we switched to the use of iPS, stem cell derived isolated lung progenitor cells, and in form of suspension and in form of organoids. And we started to look into the ability to deliver these cells into specific region of the lung, to have them there survive, to attach. We still don't have solid data for the engraftment because this requires longer studies, but so far it really looks very promising that we can do these kinds of experiments. So in order to stay on time and just to allow us a lot of time for discussion, instead of writing my own summary, this is actually summary. This is a summary about cross circulation that was written by two real giants in the field, Fisher and Dark, in the commentary that they wrote about our last paper, this human lung paper in Nature Medicine. So they really see a lot of opportunity, a lot of potential for cross circulation by saying that, sorry. Oops, I don't know what happened, sorry. So there is a number of types of lung injury that can be treated. They were convinced that there are physiological benefits, structural benefits, immune benefits. I think that Matt Bacchetta will agree. I mean, we have a little bit more skepticism. We do see a lot of challenges. I mean, immunology, especially longer term effects, are still a challenge that we need to address. We need to assess how the immune profile is really changing over time. And there is a lot to be done, but we see huge potential for lung transplantation. And in this last year, we also started to very actively use this model for studies of disease, injury and disease, for the purpose of developing other therapeutic interventions in addition to lung transplant. And let me just close with this final slide. So the picture at the left is the first night out for my lab after this very long COVID crisis. So everyone is smiling and everyone is happy. So I would like to really thank all our collaborators. They're absolutely and totally critical for everything we do. We really work hand in hand on all these projects with our clinical colleagues and with our colleagues in science and engineering, to thank all the funding sources that keep us afloat, and to also thank you for this invitation. It's really a pleasure to be engaged in this discussion of how a new technology can contribute to solving the really critical problem of treating patients that have serious and life-threatening lung injuries and diseases. So I will now stop sharing my screen, and then you can take over for the discussion part.
Thank you both so much. As much as I know about the presentation, I learn so much every single time I hear the two of you speak, and it's truly a pleasure to have you with us today. So with that, we're going to open up the line. Deanna, they can send in questions via chat. Anybody has any questions about how any of this works?
So just as a quick reminder to anyone, if you do have any questions for either of our presenters, please feel free to go ahead and submit them using the Q&A box. Again, that's going to be at the bottom of your Zoom navigation bar. You should see an icon that says Q&A.
Yeah.
Hey, Brandy, while we wait for some of those questions to come in, I think we had a few questions that were submitted during the registration process that we can probably leverage to address some of folks' inquiries.
Yeah, just pulling those back up. I'm unable to locate them. Can you re-forward to me? Apologies.
Sure, no problem. I'll send that to you, and I can start off with the first one. Can you both share any information about the outcomes seen utilizing this platform?
I think, so they're asking about the outcomes. I think that if you're taking a look at the platform and the way that we've used it, whether it was with lungs that were injured or utilizing the xenogenic platform, what we have seen is that these lungs recover a tremendous amount of function. The swine demonstrated lungs that were acceptable for transplant. We did do a transplant with one of our swine models. We obviously have not taken human lungs run on the xenogenic platform into a patient. But looking at the data, the signals that we've acquired on those, for example, the gas exchange capacity, the P to F ratio, the compliance of the lung, there was a significant improvement across all of the runs. And, you know, I think as a transplant surgeon, certainly the one that we had taken off of an EVLP system that had failed on EVLP, that lung would have met clinical criteria for transplant. Where there is no approval to do that, so we have not taken that lungs from this system and transplanted them into patients. That's, you know, obviously a long-term translational goal for us, but you know, we still have some immunologic work to do, which we are doing. It's not published yet, but we have started that work, and some of it should be coming out, I hope, soon. But there's still a lot of work to be done. And, you know, we're looking forward to doing it and moving this along.
I think in addition to everything that Matt has said about this primary application, the actual application that has driven the project all along, there is also the use of this platform allows you to investigate, to do some basic research, but more importantly, to test some of the therapeutic options. So just imagine that what we do in these lungs ex vivo, so you remove defective cells, you replace them with therapeutic cells. There are certain conditions when you can do the same thing in patients. So you can treat the lung by cell therapy. Obviously, you cannot experiment on people before you show feasibility and optimize this treatment. So this ex vivo platform allows us, and this is what we are doing, to investigate how therapeutic are different types of cells, different developmental stages of the cells, if earlier progenitors are better than later, etc. So you can really make this into the test bed, into the platform for testing cell therapy to bridge studies between human-sized animal models, such as a swine or sheep or whatever you want to use, towards the human patients, but then test the therapy on human lung before the patient. The other very obvious application is there are diseases that can be treated by, say, gene therapy, like cystic fibrosis. There are diseases that can be treated by cell products, because it's not only the cells are therapeutic, but for example, extracellular vesicles that are secreted from therapeutic cells are very off-the-shelf medicine with huge therapeutic potential. So you can also study to how to deliver these therapeutics, how much you need, what is the time progression, and this window of time that we showed you that goes to several days at this point really allows you to learn a lot about what is happening in an injured or diseased lung following the treatment. So there are multiple options for advancing medicine by enabling transplant, but also by enabling and devising some other therapeutic strategies.
Great. It looks like the next question is, how can we recover more organs from trauma patients? So maybe how is this applicable to some of the trauma population that we see in the donation right now?
Well,
yeah.
I mean, I think they're probably talking about sort of different types of master 2 donors. I think that anything that provides a platform in which organs can recover, whether it's lungs or liver, and just so you know, we have done this work in liver as well. We've done this work in other organs. We're talking about lung today, but we have also utilized this for other organs. So we'll take a slightly more general approach to this. I think that you know, there's a lot of work going on in NRP with you know, normal thermic regional perfusion for recovery of hearts, and I think that there's an opportunity here for us to explore it. There's a number of issues that surround it, both ethical, procedural, scientific. I think that, but as I said, this is an opportunity for us to consider it. And certainly a platform like this would leverage the opportunity to recover more organs. And we're actually exploring that. We are looking at that. There's, you know, when I say we, it's a general we, but also specifically at my own institution, but with other institutions in partnership, looking at methods to do that. Because obviously there's an organ shortage across all systems, not just lungs, but for hearts and livers and so on. So I would just say we'll have to wait and see what happens, but we are actively working on it.
The next question is actually about your experience using this platform on livers. And do you feel that there will be one organ that utilizes this model in the clinic before another one?
Well, our work in liver has been very successful. We have utilized this also. I mean, there's a lot of unpublished data that I think we are working on as our teams are putting together. But yes, we've run this for swine liver. We've also done xenogenetic platform liver work. Is there one organ that's better suited than another? Well, I'll just say that lung is a challenging organ in the sense that you not only have to take care of a blood supply, but you also have to have it hooked up to a ventilator. And that increases the complexity of managing an organ by a very large factor. You know, if you only have to plug in a blood supply and you can sort of just cap it in a bag or a nice little box, it does, at least from a complexity of management, it simplifies things. There are very different physiologic demands in the way that you set these organs up. In the lung, we have blood flow going into the pulmonary artery, blood flow return from the pulmonary vein back to the bioreactor. That can just be venous blood coming out of the venous system, returning into the venous system. We can do the same thing with the liver, but with the liver, we actually have to provide oxygenation. The nice thing about the lung, even if it's damaged, it's still going to have some gas exchange. And it does quite well with a mixed venous gas, because that's what comes into the pulmonary artery. So it handles that environment well physiologically. The liver is different. It requires a combination of a mixed venous coming through the portal vein, and then it also requires oxygenated blood coming into the hepatic artery, since it really has these two different, very different sources of blood supply. Now you can argue that the bronchial arteries in the lung matter as well, but it's not as physiologically relevant. So in the liver system, you actually have to have an oxygenator built into the system, and you have to have differential pressures, because the pressure in the portal vein is very different than the pressure in the hepatic artery. So there are a few more twists from an engineering standpoint. But, and also the liver is a very metabolically dense organ. It's a real factory. And so the type of support that it needs is a little bit different than the lung. The lung actually does not require a tremendous amount of blood flow to keep it alive or to allow it to recover and regenerate. The liver has greater needs, so you have to again adjust your oxygen delivery and flow rates and so forth. I don't want to make this, I don't want to go down into too deep of a dive into the details of this, but as far as is there one organ that may be better suited or have an earlier application than the other? I would, as a lung transplant surgeon, I'd like to see lung come along first, but the liver is, we've been able to manage that very successfully, and you don't have to connect it to a ventilator, which makes everybody a lot happier.
I think I would just add one sentence to this. The clinical need for the particular organs is an additional huge driver. I mean, none of this would be happening. Lung may be suitable or not suitable, but like if there was not this dire need for the lungs for transplant, there would not be research. And I think like who wins that race of the organ getting first into clinic may well be also influenced by the scale of the problem of the deficiency of organs for transplant. So it's a very complex situation, but it's encouraging to see that so many people are working on various approaches to the same problem, essentially.
Great. And with that, I think we are at time. Thank you, everyone, for joining us today. Thank you, Dr. Bacchetta and Professor Vunjak-Novakovic. We really appreciate you having shared your experience. It's so fascinating, and so it's going to be really great to be following you in the coming years to see how far your research goes.
Thanks for the invitation.
Thank you so much.
Thank you, everyone. I just want to echo Brandy's sentiments. Thank you so much for your time. That was a fascinating presentation. I really enjoyed it. So thank you both so much for that. And Brandy, thank you so much for your efforts in helping to coordinate today's program and for, of course, moderating. And of course, to our participants who are still hanging on with us, thank you so much for joining us, and we hope to see you in the future.